So, hello everyone. Welcome back to your favorite show. It's the Care OACES with Dr. Cooper. I like to call him Dr. Coop because by now I feel like we're all friends.
Yes,
Dr.
yes.
Coop, welcome back.
Thank you, Ursula. Good to be back. Thank you so much.
I do have to tell you, everyone is loving the show. Everyone is really excited about what's coming next. And I am particularly very excited
Uh,
about this episode because we're going
sure.
to talk about something that I feel is like an elephant in the room and nobody really likes to talk about. I don't know if you agree.
I agree. Yes, I totally agree with that.
And the elephant in the room is the intersection of equity and advocacy, how to bridge gaps in the healthcare access. We do know that it is not easy to get
Mhm.
healthcare for everyone. I would say it's very, very hard. So on
Sure.
this episode, we are going to talk about healthcare equity and advocacy, which
Uh,
is a critical topic that is going to combine systemic challenges, personal stories, and of course, because we are with Dr. Coop, actionable advice.
uh,
Because what's the point in complaining and realizing that there's something wrong if we're not going to do something about it?
that's
Right?
correct. I agree. I agree.
Okay, so do you want to go right into it?
Sure. Let's do it.
So, Dr. Cooper, equity in healthcare, as we have just mentioned, is a significant challenge. It has always been, but it is more so today.
Yeah.
But was there a moment in your career or in your life where you saw firsthand the inequities that patients face?
Yeah. That one hits right at home. Um, I am one of seven children in my family, and I'm one of only three of those children that's still alive. I came from a traditional family background and mother, father. There was no, um, half this, half that, none of those things. It was just mom, dad, and eight children. My mom died when I was 14 years old. She was young, 46 years old. She died of pancreatic cancer. When I think back on the time leading up to her diagnosis, I remember her having back pain and complaining of various things. I'll never forget one day I went into the bathroom behind her and there was blood in the stool. So, of course, at 14, I'm thinking, oh, well, maybe this is, a woman thing. This is a period or whatever at that age and not really understanding all those things fully myself. But what it was is actually she was having gastrointestinal bleeding from her pancreatic cancer that at that time was metastatic, and she died about 6 months after the diagnosis. When you think back on those symptoms, however, she was having symptoms for quite a long time. So even if you think about the diagnosis being made late, which is very, very common, at least at that time, it was very common with pancreatic cancer, she had symptoms. She was going back and forth to the doctor. And in fact, back in those days, they were recommending BC powders, if you've ever heard of those things, whatever's in that, subsalicylate and some other anti-inflammatory things. So, not having access to advanced type diagnostic imaging and having a high index of suspicion, here we go. That's an inequity. Okay. Why is that? I mean, we lived in a small town. You only had access to the same family doctor that everybody saw for just about everything, for delivering babies, from a toothache to pancreatic cancer. And so that was circumstantial, but it's an indication, and it tells us, it gives you the indication of where and how inequities can be very, very subtle. Um, and so that's one example. And then my entire family. I mean, my youngest sister died when she was 27 years old. You think back on her history leading up to her being admitted to the hospital for DKA, diabetic ketoacidosis. She's young, sexually active. She had what we call polydipsia and polyuria. She would go to the doctor for urinary tract infections. Well, in fact, that was probably she's having this polyuria because her blood sugar was high. She's undiagnosed diabetic, and she died literally a week after being admitted to the hospital for diabetic ketoacidosis and multi-system organ failure. But, again, she's been going to doctors, being treated for urinary tract infections, young, sexually active female. It's sort of default. I mean, you would default to that. And if you're in a place where there's, inadequate health care to deal with those things, then oftentimes they default to the least common denominator. So we can fast forward from there. And my next to oldest sister, who was a smoker, and had been diagnosed at a younger age with asthma, but developed significant shortness of breath as she got older. And she was admitted to the hospital in late 1999 with a heart attack, 37 years old, heart attack. She developed severe congestive heart failure. She was ultimately recommended to have open heart surgery, and she died as a result of that surgery and postoperative complications. Again, her situation is one that underdiagnosed, probably. The shortness of breath was probably an indication that she had coronary artery disease causing blockages and perhaps even inadequate blood flow to her heart. And so, again, you can look back on that and think, what if this or that? But embedded in that is in a very subtle way, the issue of the inequity in care access. Again, so we can fast forward again, 2007, one of set of twin brothers dropped dead of a massive heart attack. He had been seen about 4 or 5 years earlier, really didn't have insurance. Insurance off and on, back and forth. And interesting thing is that he had about age 40, he underwent a bypass procedure to reroute blood flow around a blockage in his leg. Well, if you have that at that young age, you have to assume that you also have blockages in your heart. But his heart was never looked into. And so 5 years later, after he survived the previous operation to reroute blood flow to his leg to keep him from losing his leg, he has a heart attack and dies. And then we can fast forward a little bit more. My oldest brother, who lived in California in 2010-11, we got a call that he was sort of wandering the streets and, really didn't know his name, didn't know who he was. He was hospitalized and we got involved. And in so many ways, the doctor told me through doctor speak that he was immunocompromised. So he was diagnosed with HIV and AIDS and died in February 2012 of HIV or AIDS encephalopathy. Now, that's very interesting because I've been in healthcare now for 36 years. And honestly, I can't remember the last time I saw a patient with AIDS. I see patients with HIV all the time, but it's a chronic illness now for all intents and purposes with the adequate treatment. And this was definitely the case during the period of time when he was initially diagnosed. But because he didn't really trust the system, didn't trust the medications, he decided he didn't want to be treated. I learned this after the fact at his funeral. In fact, some of his friends attended that funeral and told me this, that, we talked to him for a long time about take the medicine, it's okay. And he never talked to me about it. And of course, it's not my responsibility to be intrusive with interrogating someone about their health care who's not willfully being treated by me or who's not necessarily in any kind of doctor-patient relationship with me. So he died. So when you think about that and these stories, embedded in each one of those stories is some form of inequity, lack of insurance, lack of access, lack of competent care teams. Personal responsibility can create inequities if you decide to do things that could be destructive to your health or not be responsible in terms of how you respond to your physical health. So for me, that has been really impactful for how I comport myself and for all the things, quite frankly, that I do in healthcare. It's embedded in those stories. And so part of my life's purpose is to do all I can to help improve conditions for everyone. And so the other thing I like to say about inequity, so many times when you bring that word up, particularly in this day and age, It's a black, white thing, race, culture, ethnicity. No, it's not. I practiced um, for a number of years in areas that are a little closer to rural communities. And I can tell you right now, some of the most startling inequities to access, in particular in healthcare in rural communities. Rural hospitals are closing across America at alarming rates. And so what does that? That leaves a healthcare void. So how do you fill those voids? Well, if you think about standard approach to public health, general health, management of chronic illnesses and disease, it requires an infrastructure. And if that infrastructure has been removed and the anchor for that infrastructure tends to be a hospital or hospital system, that becomes a significant source of inequity in some of these communities. So a lot of things to unravel there, but personally, that's sort of been my personal and professional experience in dealing with and looking at the impact of healthcare inequities firsthand.
Well, first and foremost, I am so sorry for each of those losses. One thing that pops into my mind is if if this happens to the family of a doctor, then what is left for everybody else? Because one assumes that if this happens to you, then what can we expect for us also? Let's try to move on, and it's a very this is a very touchy episode, but let's try to think. I do see how you're a very empathic person, and you're a very and you feel the pain of everybody else. I guess that is what makes you a great doctor. Other than a good one. So when you see patients who are undeserved or neglected, how do you channel that frustration that I know you feel and take it into action?
Yeah, it's easy to feel frustrated when you see the same disparities and inequities play out over and over and over again. But, being frustrated, being angry, it never solves anything. It doesn't change outcomes. You have to take action, channel that energy and drive into every space that I'm in. That's what I do. I rarely ignore someone who calls me and says, hey, I have a question. I get it on social media. I get it directly on my cell phone. Hey, I just need to know, what doctor should I see? I get those things and have gotten those things over and over and over and over again throughout my career. So I respond to those things. And the frustration often comes is not necessarily in seeing it, but not being able to actually directly do something about it right then and there. So that's why I created my telehealth platform, Primo Health Partners. Why we are adding and layering on top of that our artificial intelligence tool called Trend, which will allow us to basically help people in a very meaningful way by aggregating their records, improving the continuity of care, and being able to communicate that to their providers and to the systems and resources of care that they're plugged into, pharmacies, imaging, laboratories, creating that repository so it can at least to some extent impact the information gap. So that's why I'm here on the Care OACES podcast, having conversations like this, spreading the word, having people raising awareness. Those things are very, very important. I also think that mentorship is crucial. I spend time mentoring young physicians, especially those that are from underrepresented backgrounds and communities, because we need those diverse perspectives in medicine to break down the biases that can lead to the perpetuation and propagation of unnecessary inequities.
Well, since you are here, I do have to ask.
Yes.
We know the problem, but what do you see as the root, the causes of healthcare inequities, and why on earth do these challenges persist after so long?
Yeah. So healthcare inequities are deeply rooted in my opinion, in systemic problems, barriers, and problems with our society in general. These things have been around for generations. And, some of them, the biggest factors, I mean, we've already talked about implicit bias and cultural competence. And, studies show that minority patients are less likely to receive pain management treatment appropriately, more likely to have their symptoms dismissed, and less likely to be recommended for life-saving procedures. And then you think about that alone when it comes to a racial barrier, but, it happens in very subtle ways within the healthcare environment. For example, I never allow my advanced practice professionals, nurses, PAs to lead a presentation with a patient with, oh, he's a drug addict, or, oh, he smokes X, or, oh, he shot up this, or he snorted that. Those create biases immediately just because you've created the context of a negative scenario. So we see these things happen all the time in healthcare. There are geographic barriers. Many rural, as I talked about, and underserved urban communities even have limited healthcare facilities, making access to specialists or even primary care in some cases very difficult. You imagine a large metropolis like New York or Atlanta, for example, and patients have to navigate a transportation system to try to get to that care. That creates somewhat of a barrier. And then, you have the socioeconomic status. If you don't have insurance or you can't afford co-pays and other costly things, you're less likely to seek preventive care. We know this. And that leads a lot of people to wait till later in the diagnosis or later in the course of their illness to seek treatment. And oftentimes that means a late stage diagnosis and perhaps even worse outcomes. And then there's also the issue of health literacy. Patients who don't understand their diagnoses or treatment options can't make informed decisions. And really they kind of do the throw your hands up thing where they basically just give up. And this leads to poor outcomes. And, you layer on top of that, most recently, in the last, 10 years, in the last 5 years, we went through the COVID pandemic and all of the misinformation and hype and asymmetric information that persisted as a result of that. And so some of that mistrust for the system still exists. These things are built into the fabric of our healthcare system. They go back decades, centuries. A lot of very unnatural, nefarious things were done in the name of advancing a cause or an interest or some other reason. But those things, quite frankly, were very hurtful overall to the healthcare system. So, change requires a multifaceted approach. You have to policy, yes, you have to deal with policies that do not passively reinforce inequities in healthcare, cultural shifts in medicine and technology that break down access to barriers. These are things that we can look for and use to really make an impact.
I was actually going to ask you about that because you are a person that takes action and that doesn't stay in the complaint area. So what specific changes in policy or healthcare practices you believe could have the biggest impact on equity?
Yeah, I think that's a great question. So absolutely, a few key policy things that I think are, could make a significant impact. And I think studies have shown this. We've been arguing, it seems, about this expansion of Medicaid and Medicare access for decades. It seems to never go away. But many patients fall into that gap where they earn too much to qualify for Medicaid, but not enough to afford private insurance. They are hourly workers where the cost of accepting even the employer-based plan would basically usurp their entire paycheck. So expanding support for these programs and to provide that coverage is going to be very important. It doesn't look like that's going to happen in this current political environment for now, but we can't stop. We can't stop talking about it. We can't stop advocating for it and being stewards of good information and good policies that are going to make a difference. And of course, the same issue here with mandating bias training in medical education. We're getting rid of DEI programs right now, but we need to train physicians to recognize their own implicit biases and improve cultural competence in patient care. It's very important. It makes a difference. I have, I have a gift because I don't really, and the people that I work with oftentimes, you just have such a way of connecting with people because I see them as humans first. And I see when I look at them, I see myself. I see this connectedness that transcends, your skin color, your whatever, the tattoos on your skin or whatever. You're all humans, and so am I. So I think it's very important that despite this transformation that we're going through throughout our society today, as it relates to bias and diversity and those things, we should be steadfast. There's people out here to understand the importance of that. I think, putting people in a position to have a voice, and then empowering them. I will tell you that one of the things that I'm biased, if you want to use that word, is remote care, virtual care, investing in telehealth. And I think, and we've seen some progress in these areas where we're getting more and more regulations that encourage and not restrict the use of virtual care, not just for the general population, but even in underserved communities. Communities like veterans, for example, with the expansion of veterans telehealth services. And then, but giving people really a place to embed their digital life journey. That's what we're doing with our trend, artificial intelligence. It's not about turning over the decision making and care to to an algorithm. It's about facilitating our ability to connect with people and create that trust, break down those barriers, and give them a home. I have a vision that one day we will have healthcare that has essentially eliminated completely the terminology of inaccessible or access, because access is literally at your fingertips through a mobile phone or a device of that nature. So these things won't happen overnight, but strategic policy changes, community engagement, engagement with healthcare institutions, providers, nurses, and the entire healthcare ecosystem is really going to get us moving in the right direction, or continue us in that direction.
So to advocate is such a powerful tool for change. What does being an advocate mean to you? And and I think this is very important, how can listeners start advocating for themselves or for others?
Yeah. To me, advocacy from where I sit as a provider is about using your voice and your platform to create meaningful change. As a physician, I advocate by educating my patients, challenging biases in medicine, and pushing for innovation that improves access to that care, to great care. So for listeners, advocacy starts with education and engagement. You have to know your rights as a patient. You have to engage in this system, ask questions, seek second opinions, and don't be afraid to speak up about your health concerns. And, the reality is that the system has not really made these things easy. Okay. We are very, very paternalistic in our healthcare system. And so it is incumbent upon patients to understand that these resources do exist. Primo health partners exist. We're layering on AI that's going to take it to an entirely new level. These things are very, very important. And there's a support from community health initiatives. Look around you to know what these programs are. If your city has these programs for free screenings, community clinics, spread the word, volunteer, engage, get yourself active in being proactive about what's happening with yourself, but also with your community, and get involved in the policy discussions. Call your legislators, vote on healthcare initiatives that you have the opportunity to do so, and demand equitable healthcare policies and practices. And then, I know those are tall order issues.
But you know what? I think that's a very important point you touched right there. It is about you. I think that's what everyone should understand. Get involved. Do not wait until you have to go to the doctor.
Right. And so it's, for me, again, creating these platforms is just about that. It's about getting that word out there, but also having people understand you can reach out to us. You can talk to us. We're real people. We want to help. Tell us what your problem is. Medicine is, because of the business of medicine, has become very, very much so transactional. That's why the name of my company is called Partners. We want to be your partner. It's not about a transaction. Well, yeah, you got to do that from the business perspective, but the reality is we want to partner with you, create a relationship that's sustainable, and have us be a resource for you as you try to navigate this very, very challenging, confusing at times, healthcare marketplace.
Well, you were just talking about IA or AI, actually.
Yes. Mm-hmm.
So, what role does technology or innovation play in trying to level the field for undeserved communities?
Oh, yeah. Technology to me is one of the greatest equalizers in healthcare. When used correctly, of course, everybody's concerned about the nefarious use and use for harm, and we have to be concerned about those things. But I also am a very positive person, so I like to look at all new technologies that come along. I embrace them in healthcare. And then there have been waves of them, from electronic health records to new medical devices to now AI in healthcare. And there's just been so many things that come along. I personally have been one to always embrace the change, because the reality is oftentimes change is inevitable. And once change gets going, you can find yourself way behind the change line. And that's not a good place to be. So, AI, telehealth, can remove a lot of those traditional barriers to care. Diagnostics that help, and again, if well, I don't want to be treated by a machine. Well, here's the reality. Okay. The data is out there. Okay. The so-called machine that you are poo-pooing is actually almost just as good as you are. I mean, it is what it is. But you don't have to be defensive about that. If you embrace that, you can find ways that it actually helps you do your job better, detecting these diseases earlier, reducing disparities in late stage diagnoses. Okay. Helping you become more efficient in your work, in your workplace environment. Telehealth services for people with chronic conditions who just go in to have, to have the doctor sort of look at them and click on the computer while they're talking to them through the side of their side eye. Those are things that we can overcome by utilizing technology. So you think about wearable devices and remote monitoring that allow people to kind of manage some of these chronic conditions. So we've got to start understanding the power that we have. Think about it. Most of us have on some kind of a walk around all day long with these devices, the Apple Watches, the Fitbits, the Garmins, or whatever it is, or whatever our device of choice is. Where does that data go? Do you ever think about, what do you do? So you look at it instantaneously. Oh, my blood saturation is 98%. Oh, my heart rate is, but what does that mean? So you imagine if you could continuously monitor that information, what they call PGHD, or person-generated health data, to affect or to pick up trends in their health care that could be, could indicate a disease. And some of these things have gotten so advanced that the biometrics and the things that it's monitoring are tremendous, from your temperature to your blood pressure to your oxygen saturation to literally your blood glucose level. And so these things are really, really exciting. You imagine using technology to reduce medical errors. Okay. We still have a very human-centric process in a lot of hospitals, two-nurse documentation before medication for certain medications are given, timeouts in the operating room, and those kinds of things. Important, but quite frankly, the reality is we still make mistakes. And so using technology to help facilitate those interactions is very, 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 very important. I think one of the challenges is going to be, getting access to technology, and not just to those people who can afford them, but to figure out how we can have initiatives out there that ensure that communities that are at most need can get access to those things. And so, that's part of our mission at Primo Health, part of the OACES Care, is ensuring that we use technology to serve everyone and not just a select few people. But technology is going to be very, very important, in my opinion. Yes, every technology can create harm. I mean, it's amazing how it seems like the narrative around these things is just so accentuates the negative. And I try to stay positive because I see so many positive effects of having these types of technologies out there.
While listening to you, I was thinking that many people are afraid of technology and think that technology is not going to give them like the best advice or going to be good for them, or the technology wouldn't know as much as a doctor. But still they trust an autopilot when they fly a plane over the Atlantic Ocean. So they trust technology on a plane, but they do not trust technology for the healthcare.
Imagine that. Yeah. Mm-hmm. Yeah.
So what is your vision for Oasis Health? To create a more equitable healthcare system. How do you think the Oasis Care is going to do that?
OASIS stands for omnipresent, O, access, A, to care, healthcare, C, E, experts, healthcare experts, and S, healthcare services. And that name is intentional. It is my vision that we create an ecosystem where access to quality healthcare is not determined by a zip code, income, background, or any of those things. Okay. So, it is truly a place, you think about an oasis in a desert, and it's that one place where everybody comes to drink. So you imagine that we're creating the place where everybody can come drink of this nectar of good health and good health practices. So through the combination of AI, telehealth, the strategic partnerships, provide real-time access to medical experts no matter where you live, use AI-driven tools to give you access and continuity of care across different, regardless of what it is you need, empower patients to own and manage their own health data through one of our tools called Access MD. So, healthcare, I certainly believe that healthcare is a right, not necessarily a privilege. But in this society, it's almost become default that it is a privilege, because if you don't have resources, oftentimes you don't have access. So Oasis Health is about building a patient-first, tech-driven model that makes equitable healthcare a reality for everyone.
Actually, I was going to tell you while I was listening to you and you were talking about how difficult it is for a patient to access healthcare and how difficult it is to actually get treatment or get something. A few days ago, I was traveling, and people that were traveling with me were positive for COVID. So they told us that they were positive for COVID. So I decided, even though I had no symptoms, that I wanted to get tested, just in case, because I wanted to be responsible. There are no tests in the stores where I live, none whatsoever. They don't exist anymore, because since it's not a pandemic, then they don't sell those anymore. I called the doctor to come to my place, and she said, but you are not coughing and you are not sneezing, so you don't have any symptoms. And I said, well, I don't, but I might have COVID and I might be contagious.
Right.
And she said, yeah, but you know what? Even if you tested positive, and I am not going to test you because I do not have a test, but even if you tested positive, I mean, you have the vaccine, so you wouldn't be told to stay home. So basically, it's the same whether or not you have COVID. So I was thinking, some patients do try to do the right thing, and it is the system that forbids you from doing it. Had you ever thought about it?
Mm-hmm. Mm-hmm. Yeah, that's a very good scenario. And so you think about that provider brought all of their own personal biases, some perhaps clinically relevant, perhaps backed by data. But think about the other component there. That was an opportunity, quite frankly, to approach that differently and engender trust. in you. But instead, the approach that this provider took basically just reinforced your distrust and mistrust and despair from the system. And so, although, okay, good. What are we going to do differently? Yeah, no, but how can we deliver that message in a way that's a lot more reassuring for the patient rather than just, because that sounds like the way you presented that conversation sound like she's just, sort of blowing you off. Okay. And that happens in healthcare, unfortunately, way too much. Look, I'm not here to take on your burden per se, emotionally or any of that thing. But as a professional, I do have an obligation, I think, to address your problem in a very professional manner whereby even if I don't tell you what you want to hear, I told you what you needed to hear, okay, in a very professional way that delivered the message, and you basically were okay with that. And so I tell patients that all the time. I may not have the answer, but two things I'm not going to do. One is I'm not going to tell you I have the answer and I don't. I'm not going to tell you a lie. And if I don't, I'm going to tell you I don't. Okay? So, I mean, and we're going to be able to communicate with each other on a level playing field in regards to information. But here's also the other component of that. I'll do all I can to figure out, what we can do, okay, to try to help facilitate and help you navigate whatever the difficulty is that you're having. And so people, this used to happen early in the days of Google. They would bring in the Google sheet where they printed something off. Everybody's so excited about Google. And I had this lady, she came in and she had printed off some beautiful dissertation from Google back in those days, probably however long ago Google was founded. But she brought this in and she was convinced that, this is her issue. And I said, ma'am, this is fantastic. Okay. I said, I'm so glad that you did this because this tells me that you're really engaged and you're really concerned about your condition. Okay. But I do have to tell you that the condition that you printed off really has nothing to do with what we're going to talk about here today. She's like, what? They told me. I said, but it's in a totally different context, unfortunately. Okay. But, she was, I presented it in such a way that, look, it wasn't, oh, that doesn't mean anything. I didn't blow her off. And, no, I said, no, you take the positive direction, which says that and quite frankly, I was very happy that she's an engaged patient. We're going to have a good conversation. She's going to go and do her research after she leaves, and she may come back with more poignant or more direct questions related to her condition. But she didn't, because we did a great job of thoroughly covering everything in that encounter. So, we see these things and I think the other thing that's happening here is we have such a fast-paced a rate of new information being put out there as it relates to health. You think about COVID, for example. I mean, gosh, you go search COVID now. It's everywhere. You think about the weight loss craze, for example, with the GLP-1s. It's just so much information. And then what happens is that, to some extent, in defense of practitioners, is everybody thinks we've got the answer for everything. Well, no, we really don't. Everybody thinks I can remember all their health records. Well, no, I can't. Okay. I can go through a snapshot and look at your record when you come to see me. But I really have no idea why you got here. And people say, well, why? I get that question all the time. Why did I develop this? I ate right. I don't smoke. And you have to go through all of the potential risk factors. I'm talking about coronary artery disease right now, with them to try to identify what those issues are. And it can become challenging.
I enjoy our talks so much, but I need to go to the last question, even though I could stay, but it's already been like 45 minutes. So Dr. Cooper, we do have to wrap up. I am looking forward to the next episode, but I love when you give advice to our listeners. So for those listeners who feel powerless in the face of these inequities, what advice would you give them to navigate the system and advocate for themselves and for loved ones?
Yeah. So, if you feel like you're not being seen, you're being marginalized, you're not being heard or mistreated by the healthcare system, just remember, unfortunately, you're not alone. I hate to say that, but you're not alone. But you also deserve better. In addition to that, know that there are professionals out there like myself and others who really do care, who want to hear from you. Okay. And also just be encouraged that I think despite the state of our political climate right now in America and the state of our healthcare system and the changes and the just it seems barrage of new technologies coming at us, change is coming, but it's going to be positive. But I think you also have to engage, empower yourself, never stop asking questions, demand clarity, get second opinions. That's why we exist at Primo Health Partners, Primo Professional Resource for Independent Medical Opinions. Come and see us. If you have those questions, we can help you get your records and then give you an idea of what's going on. Utilize the technology that's out there. People are buying these things and they're just, they're like little trinkets, but utilize technology to take control of your medical records, your health decisions, your choice of providers, and then use that to connect with those providers who do listen and who do respect your concerns. And to those people that are in healthcare, our healthcare providers, we have a responsibility to all do better, continually seek to improve our professional decorum and how we deliver care. Equity isn't just a policy issue; it's a moral obligation, in my opinion. We have to ensure that the care that we provide is fair, just, and that we provide access to all that. That's our oath. That's the oath that we all took. And I think together we can all create a system where, nobody gets left behind. So, it's all of these things are really part and parcel to our personal experience as human beings, looking at the system as a whole and then thinking to ourselves, okay, what can we do to make a change for the positive? So, let's keep it up. Let's keep talking. Let's keep engaging. Let's keep looking for solutions. Thank you.
Dr. Coop, thank you so much. I'm looking forward to the 4th episode of the Care OACES. And
Awesome.
As usual, it's a pleasure and a joy talking to you.
Awesome. Thank you. I look forward to it as well, Ursula. Maybe we'll be back in this beautiful setting again next time. Okay.
Hopefully.
Awesome. Take care. Have a great one.